from the Children's Hospital at the University of Pennsylvania, and she's going to be talking to us about equity in autism identification and care. This is a really important topic. And I know there are a number of teachers who are going to try to sneak in to see at least part of this, because there are a lot of concerns about this in some of our bigger cities here in Connecticut and beyond, Bridgeport, New Haven, and Hartford, about issues of equity and underdiagnosis. And I think we're going to hear a lot from Kate about just that topic. So Kate, take it away.
Great. Well, thank you so much for the invitation, for having me today. I am really excited to share something that I've been thinking about for a long time now. I actually wrote my undergraduate thesis on a related topic. I don't care to say how many years ago now, but it's been quite a few that I've been thinking about this. I'm excited to share, and lots of updates over those last couple of decades, I would say. I have no financial disclosures. I always want to start any of my talks just acknowledging the land where I am. So I'm coming to you today from Philadelphia, which was the land of the Lenni Lenape people, and doing a land acknowledgement at the beginning of sessions helps to just minimize the erasure of Indigenous people and bring to mind their claims to the land. I'm also going to talk probably about things that may make people feel a little bit uncomfortable. So I always just want to say, take a deep breath. We're going to be in this together. There is sometimes you might feel a little bit uncomfortable with some of the things I want to say. I might also get things wrong, and I just want to come to this with tremendous humility that I'm learning, and we're here learning together. So we'll start with just deep breath, a morning cleansing breath, and we'll get started. So today we're going to talk about disparities in autism diagnosis. I'll give you some data. We'll talk about some foundational concepts after that, which I think will be really important, just some terms that I use and help to understand, make sure we're speaking the same language about some of these things. We'll talk about how do we think about mechanisms for identifying disparities. And then at the end, hopefully I'll provide some of my thoughts about some solutions that are either things that are ongoing or could be potential opportunities. All right, so to get us started today, I'm going to speak about one of my patients. So I saw this little boy when he was just over 5.5 years old. I actually saw him right before the pandemic started, so in the winter of 2020. His parents spoke English, and they had immigrated from East Africa. He had been born in the United States. And when he came to see me, he was noted to have decreased interaction with me and with others. He had really fleeting eye contact. He had difficulty engaging in any kind of conversation. He demonstrated frequent echolalia. He was scripting a lot from things he had heard previously. He would engage in repetitive movements and sort of pace around the room, briefly would spin. And he was having a lot of difficulties reported by the family with behavioral inflexibility, with just significant rigidity. He'd only recently, even though he was 5.5, begun using more than one word to communicate with others. And as a result of some of these behavioral challenges, and especially his behavioral rigidity, he had been expelled from his kindergarten and was asked to go to a different school. So based on this, I mean, I think it's pretty clear that he met criteria for autism. And it wasn't a particularly subtle case, I would say, especially given some of the language delays and really pretty fairly clear presentation, despite the progress, of course, that he made most recently. So this really got me and our team thinking about how does a child how does it come to be that a child with a fairly straightforward presentation of autism doesn't come to diagnostic ascertainment and come to our attention until after age 5. And we know that this is well above the national average. So he was diagnosed at 67 months. At that time, the national average was estimated at about 52 months, and we've since made some progress there, and we're closer to about 45 months nationally, and I'll talk about where some of those data come from. So it really got us thinking, and unfortunately, Ben's case is not unique, but pretty representative of some data that we've known for quite a long time. So really over the last 20 years, a lot of the information that we have been tracking regarding autism diagnosis has demonstrated what you see depicted here on this screen. And this is data from 2014, but this has been the case for many, many years, and which shows that white children were more likely to be diagnosed with autism than Black, Hispanic, or Asian or Pacific Islander groups. And these are the groups that have been tracked and monitored and categorized in this way by the CDC, the Autism and Developmental Disability Monitoring Network, which is one of the largest surveillance autism networks that's been in place for about the last 20 years or so. So recently, the data actually are quite unique, have switched a bit. So the most recent iteration of this data uses information from 2020. It came out just last year. And for the first time, in both 2018 and then really 2020, it was the first time that there was a statistically significant difference, such that non-Hispanic white children, who you see depicted here in the green all the way at the right side of the screen, were diagnosed at lower rates than non-Hispanic Black, Hispanic, or Asian Pacific Islander children. So that was interesting, and sort of had flipped what we had long seen as the disparity in diagnosis. So, okay, end of presentation, we're done talking, right? Well, let me show you that this is not really the full story. So let me dive in a little bit more. So just shown another way, for every 1,000 children, 24.3 white children were diagnosed, 29.3 Black, 31.6 Hispanic, and 33.4 Asian or Pacific Islander. And actually, we had put out a study looking at prevalence across the CHOP primary care network, which included over 26,000 children, and had found actually the exact same pattern. So our data came out a few months before this, and we were really encouraged to see that actually our data really fit this national trend. But again, this doesn't show the full picture. So let me dig in a little bit more to depict where there are still some issues that are concerning, and we haven't completely solved all of the disparities with autism, as I'm sure many of you can attest to as well. So let me dive in a little bit to how does the ADAM network, the Autism and Developmental Disabilities Monitoring Network from the CDC, actually come up with these numbers. So what they do is they do active case ascertainment, which means that they have teams of reviewers at different years have different numbers of sites, but generally about 16 sites, I believe, across the country. And they have teams of reviewers who look at either or both of educational and medical records, and actually comb those records to determine how many children actually have sufficient number of indicators that suggest that they would meet criteria for autism. So those total numbers that I presented to you are actually that total amount of children who would meet criteria through active case ascertainment. But unfortunately, what they've found is that when you look at children who would meet criteria and compare them to children who actually have a diagnosis, what we see is that therein a disparity persists. And so these are data from Lisa Wiggins and her team that looked at disparities in documented diagnoses versus those that made that
question. Who gets transfers from other LIDAs? Who's the point person?
Sarah.
Sorry.
Sarah Holt.
All righty, thank you.
I didn't.
Sorry. And so here when you look at the number of children who actually have a documented diagnosis and compare them to those total cases, what we see is that compared to white non-Hispanic children, Black non-Hispanic children are 1.7 times more likely to have undiagnosed autism. Not other non-Hispanic groups and Hispanic groups are 1.6 times more likely than white children. And so even though when you actually look and try to determine who has enough characteristics to go along with autism, those numbers those gaps are closing. Actually, who carries the diagnosis there are some disparities there. And that's so important, as all of us can attest to, because having that actual diagnostic label, unfortunately, in many ways, is that indicator, that marker that qualifies children to get additional supports and services in many cases. So that diagnostic label is critical because of how our system functions in getting children qualified for getting autism specific services. So another complicating factor is actually when you look at who's diagnosed and who has co-occurring conditions. And so this was data back again from an earlier iteration from the 2014 wave of the ADAM network. But what they found is that if you look at the bars here, the lightest color tan indicates that the child with autism has average or above average IQ, and any of the darker brown, tan and brown colors indicate either borderline or intellectual disability. And what we see here is that white non-Hispanic children are way more likely to have autism and average to above average IQs compared to children from the other groups. In the most recent iteration, even though, again, more non-white children are being diagnosed with autism, or being identified rather with autism through the ADAM network, what we find is that the rates the rates of intellectual disability are significantly higher, especially for Black children. And so this suggests one of two things. One is that we're still missing children who identify as non-white, and particularly Black, who have autism and average to above average IQ. Or another hypothesis is that there are delays in identification and diagnosis are actually contributing to the development, especially in Black children, for having concurrent intellectual disability. So this is a study that I'm presenting that was done by John Constantino and team. And he looked in depth at a cohort of Black children. And what they found is tremendous delays from the signs of initial concerns being brought to attention and diagnosis. And so children, like many children, the children in this cohort had first concerns before the age of 2, but were not diagnosed until above the age of nearly 65 months. So again, this and John Constantino's hypothesis and explanation is that actually all of these delays in diagnosis are factors that are contributing to missed opportunities to intervene, to support these children, to help them develop skills. And so later on, they do meet criteria for intellectual disability. So there is actually some suggestion, at least, that the latter explanation is at least one of the factors contributing to that, to some of these disparities in co-occurring intellectual disability and autism among Black children in particular. So in thinking about this, what we did was we came up with this sort of roadmap to really depict all of the steps of the process. And for those of you who are not clinicians, I do want to go through this to make sure that people understand sort of the steps that tend to be needed to actually come and reach access to autism-specific services. So from the time that there are initial concerns, or a child attends a pediatrician visit at 18, I'm sorry, I'm seeing there's a typo on this, it should say 18 or 24 months. At which time those are the ages when the American Academy of Pediatrics recommends that autism screening occur universally, regardless of concerns. And then if a child screens positive, or if those concerns rise to the level, those children then should be referred for an autism evaluation, as well as referred to intervention services. From there, they complete the autism evaluation, go on to get diagnosed, and then access autism-specific services. Or if they are found to have other developmental delays or diagnosis, then they can access potentially more general intervention services for developmental delays. So it's quite a long process, and it's mapping this in this way helps us just think about, okay, where along this pathway are there possible times when we might introduce potential disparities that might be leading to some of those data that I suggested. So far we've really been looking at disparities in diagnosis, but I think it's also really, really important to think about beyond that, what do we know about access to autism-specific services? So I'm going to present a study that was done in California, looking back at data from 2012 to 2013, but I haven't been convinced that this trend hasn't persisted beyond that, even though the data are a little bit older. So what you're looking at here are the black line along the top is the reference group, which is white individuals. And in California, basically across the lifespan, what we see as expenditures for autism-related care tends to be lower for children, for individuals, children and adults, sort of across the board compared to white children. And this becomes particularly stark, it seems, after the age of 21, when these individuals would age out of educational-based services, and expenditures for their autism-related care just really plummets compared to white individuals. There have also, this is not the only data that exists, but there have been reviews and things that have come to the same conclusion, that support and services and service access for non-white children, even among those who are diagnosed, is significantly lower for children who identify as non-white race. So going back to our thoughts about Ben and my case about Ben, he really fits a lot of these national trends that we know, coming to diagnostic ascertainment late. And then in thinking about services, we know that he was grappling with a financially strapped public school system here in Philadelphia. And he also had limited access to home-based behavioral therapy. I'll say that in Pennsylvania, actually, we have quite generous autism-related services that children with an autism diagnosis can both qualify for medical assistance as a form of secondary medical insurance, and through that can also access ABA therapy and other behavioral therapies. However, wait lists are tremendously long, and I have children who have waited literally 2 to 3 years, and just their families are just waiting for a call for an ABA service provider, which is not generally the case for children who have private insurance, where they can actually get it established behavioral therapies within a couple of months. So what do we think is going on? So I'll pause here just to see if there's any questions before I kind of take us into the next parts of this talk. Is there anything in the chat, Eileen?
Yes, there's just one question from Wendy. She was just curious if the IQ tests used were culturally sensitive.
Really, really, really good question. I actually, I don't know what tests they use, in part because the educational records, the data from the ADAM network is not sort of, they're not going out and administering one particular test. So they are just gathering data from what's documented in the record. So I imagine there are a variety of tools that are used to come up with that diagnosis of co-occurring intellectual disability. But it's a really, really important point, and really important piece to think about is how accurate are those data with respect to some of the cultural differences and cultural cultural influences on IQ measurement. So thank you. I think that's a really good point, but not one I can fully answer. But I do think I know that there are a variety of tools just based on what sort of tools the schools themselves are administering to contribute to that educational record that make it into that educational record.
That was the only question that had come through.
Thank you. All right. I just want to go through a couple of really foundational concepts because I would hate for anyone to walk away from this discussion with any sort of misperception about what are we talking about when we're referring to race. So I just want to be crystal clear that when we're talking about race, I'll quote here from Dorothy Roberts, who wrote this fantastic book called Fatal Invention, really about the creation of the socio-political term race. And she describes that race is applied to human beings as a political division. It's a system of governing people that classifies them into social hierarchy based on invented biological demarcations. So what I want to be clear is that I'm not talking about anything sort of genetic or biologic in function, but because in fact, those genetic differences don't map onto our conceptions of race with any sort of accuracy. And there's actually more genetic variation within racial groups potentially than between racial groups. If you need any convincing that race is really a political rather than some sort of innate biological difference, you can look at the census through the past couple of centuries in the U.S. And these are very small slides. I don't want you to think about reading each box, but what you can see is that each different colored box is referring to different racial groups as they appeared in each iteration of the census. And so just the variation that you can see across time demonstrates that really these are groups that we're coming up with as people, and that there's nothing inherent to them. Some groups are added, some groups are taken away over time. And so that's really a consequence of decisions that we make about how to classify people. Similarly, this is really complex. So here are data from the 2020 census. For every box that's orange, that's representing individuals who define their grouping just in one group. But everywhere that you see a green box, those are people who identify as more than one race. There's some combination that they're indicating. And this was a really huge increase. This was the first time that people had the option to really demarcate that. And we can see that, especially for particular groups, they're choosing more than one race. So no one fits neatly into any sort of box. So I certainly don't want that to be the takeaway message either. And yet it's really important to think about disaggregating a lot of our data so that when we are looking at some information about autism, we can really detect these disparities. So it's important to measure race, but also to recognize what race represents and its limitations. And then there's a lot of information related to different identities and intersectionality. And I would say a lot of my work and a lot of my research really looks at the interaction of race and disability. I also think a lot about language status, nationality, immigration. And so all of these are contributing to individuals' identity. And so any one sort of box or category is not going to fully encapsulate anyone's unique identities. And then another important consideration is when we're talking about race, what actually are we really talking about? What are we trying to represent? And so there's this idea that comes from Dr. Kamara Jones, who is a public health expert and scholar and has written a lot about race and racism. And she describes that in some cases, how one's identifies their own race, their self-ascribed identity might be important. But in other situations, how society identifies and classifies their race might be more important. And there are often discrepancies between those two things. And when we're thinking about race, we're thinking about potentially proxy measures for things like socio-environmental exposures, in particular because we know about neighborhood segregation and environmental injustices that have clustered around places where predominantly non-white people live. Are we thinking more about genetic ancestry? So genetics themselves aren't the race as a genetic marker is not valid, but there is certainly ancestry might be a better way to describe trends in migration patterns that do lead to some clustering of genetic patterns by group. And are we thinking purely about experiences of racism or some combination of the above? And so when we're talking about this, it's just really important to think about what element of this are we talking about? And as researchers, what are we describing, and trying to be really specific about that. The other term that I just want to describe is how do you distinguish a disparity from a difference? And so here I think this is a really nice depiction that there might be differences in quality of healthcare outcomes between minoritized and not minoritized groups, but that those become disparities when they're reflective of some sort of operational system, discrimination, or structural sort of factor. There might be reasons for differences related to clinical appropriateness, patient preferences, et cetera, but those become a disparity when they're really reflective of some sort of more systemic injustice. And that's what we're really talking about today. And just for rounding out the definition by when we're talking about equity, I like this. This comes from the Maternal Child Health Bureau, where they talk about health equity being the state in which everyone has the opportunity to attain their full health potential and no one is vulnerable from achieving this potential because of their social position or other socially determined circumstances. Going to so regardless, if we're looking at some of these racial disparities, we should really be thinking upstream. So what is it about the structural factors and discrimination that might be contributing? And is that differences in employment opportunities, neighborhood, education, quality and access, healthcare, differences in intergenerational wealth, for example. So I think as we're thinking through what are driving some of these disparities, these are giving us some opportunities of where we can be thinking. So far in this work, I've really talked about like detecting disparities, but in the next phase, I want to help us think a little bit about how do we really start to think about understanding where they come from, and ultimately in the last step, we'll talk about reducing. So this is a model of the health disparities research agenda that comes from Amy Kilborn and her team. And another framework I just want to pose for you is, this comes from the National Institute on Minority Health and Health Disparities, one of the NIH centers. And they help us think through, can you look at various factors that might be at play? And so when we apply these levels of influence and domains of influence to autism, we can really rule out a lot of things, because we know that, exposures, community illness, our sanitation, for example, are not the drivers of these disparities. But really, I want to hone in, and a lot of my work focuses in on sort of medical decision making, and how do we as a medical community think about improving the equity of detection. So using this framework sort of led me into thinking about the mechanistic inquiry, which I'm going to present in this next section. Any other questions before I kind of jump in? I'm going to take a sip of water.
We've had no other questions so far.
Thanks, Eileen. All right, so going back to our roadmap can be another way to help us think about where do some of these disparities in particular autism diagnosis come from. So what I'm going to describe here is a study that I find absolutely fascinating that came out in 2021. For those of you, I'm hoping that some people are familiar with the implicit association test. Harvard has their Project Implicit, where you can actually take tests about all sorts of implicit biases that we all may hold. And what they do is they take photos and words and determine and calculate your implicit bias based on how quickly you're associating some of those images and words. And so this team actually looked at, and this is a study among college students where they looked at characteristics of autism and conduct disorder and showed photos of Black children and white children and looked at implicit associations that existed. And what they found is that there were a lot higher implicit associations made between white boys, and all these children are boys, and autism, and there were higher associations between Black children and conduct disorder. And so this is some evidence that's still in our minds. And, I think this speaks to a long history of autism really being considered a condition that impacts white middle-class boys, to be fully transparent about sort of where the history has led us. And so even among these college students who participated in this study, they continue to sort of carry that implicit association between white children and autism, and unfortunately Black children and conduct disorder. My next area of inquiry that I'll share is a little bit about our team's work. We've been looking a lot, and I started with this roadmap to really lay out the screening process because autism-specific universal screening was recommended by the AAP to try to the American Academy of Pediatrics to try to ameliorate some of these disparities. So if we look more universally for signs and symptoms of autism, do we get more equitable identification? And so what I'll present to you is we had done a very large study. I sort of had mentioned this cohort previously. We've looked at it in a variety of ways, but looked at all children within the CHAP Care Network who presented for a well child visit between 16 and 26 months, which are the ages at which automatic electronic screening for autism using the modified checklist for autism in toddlers, or revised versions, pops up automatically. And then those who continue to receive care after 4 years of age, so that we can look at rates of screening completion and then look at some of the psychometrics of the test based on who was later diagnosed with autism. And what we found is that among nearly 26,000 children that presented for well child visits, we're doing a pretty good job. 91% of them were screened at least once, although that dropped off quite significantly to when we looked at who screened twice at both 18 and 24 months as per the AAP recommendation. But importantly, what we found is that the children who were not screened at all were more likely to be non-white. They were more likely to be from homes where a language other than English is spoken. They're more likely to be publicly insured, and they were more likely to have a lower household income calculated at the neighborhood level. And so coming back to Ben, where did he fit in? So I looked back through his chart to try to understand what happened to him. And interestingly, he had a false negative screen at the age of 18 months. And some of the data I didn't present is actually psychometric calculations found lower accuracy of the MCHAT in our cohort for non-white children like Ben. And he was never rescreened, unfortunately. And what we know is that a second screening at 24 months actually really improves the sensitivity and specificity of the screen, but that didn't happen. He had a brief insurance lapse, and then when he returned back to care at 27 months, the screener didn't trigger automatically, and so he never was rescreened. So again, for him, some missed opportunities that could have brought him to our attention earlier. And then we wanted to look also at the provider behavior related to screening. So screening is only useful if it triggers some sort of action in response to a positive screen. And so we wanted to look at kids who screened positive and then look at who got referred for any sort of supports or services or for an autism evaluation. And so we looked at a cohort of over 2,800 children who screened positive. And what we found is that a good number of them had previously already been in early intervention services, as documented by, there's a drop-down menu of like, what does the provider do in response to a screen, as well as we've looked at manually reviewed a lot of charts just to see what sort of actions were taken. And those who previously initiated EI even before the time of screening were more likely to be more likely to be white compared to Black or Asian children, and were more likely to come from households where English is spoken. Among those who were referred to early intervention on the day of a positive screen, they also were more likely to be white and more likely to be English speaking than Black or from a home where another language is spoken. And only 11% of children who screened positive were actually referred for an autism evaluation. And again, those children were more likely to be white. There, the comparison that was significant was compared to Asian children, and they were more likely to be English speaking. But 42% of children left that visit without any immediate referrals being triggered or not having previously been in early intervention. And those children who were not referred at all were more likely to be Black, Asian compared to white, or from a home where language other than English is spoken. So there's some evidence that even when children screen, even when they screen positive, we are not attending to and making the same sorts of decisions and what to do in response, which again is unfortunately a place where disparities could really present themselves. And interestingly, so we did the same, I just presented the autism specific study today, but we did the same study with respect to general developmental screening, which is also recommended by the American Academy of Pediatrics, and found very similar patterns that children are not equitably being referred after a positive screen. And this was the case as well for Ben. So he did screen positive for a general developmental on a general developmental screen at 9 and 27 months, but he had no referrals made. So again, for him, missed opportunities for coming to early attention. All right, so I have painted a big picture of a lot of the challenges that exist, but I'm hoping to leave us with a little bit more hope than that. And I think the other way to look at that roadmap that I presented is that anywhere that there's an opportunity to introduce or exacerbate a disparity, it's also an opportunity to intervene. And so in this next section of the talk, I'm going to talk a little bit about how are we thinking about actually reducing disparities. And again, so here's our roadmap. Each of these points could potentially be an opportunity for us to intervene. So what are we doing? I will say that there are some novel screening tools that are being developed, which may improve detection for children at young ages. So a new tool was introduced and has been studied, which uses pictures to sort of illustrate some of the points made in the question. So it's still looking at autism-specific behaviors or behaviors that go along with concerns for autism, but use pictures to help depict it. So for example, there's a girl and the parent is shouting her name, and there's a picture of that happening to ask about whether the child responds to name. And this is really targeted to help support screening in individuals who have lower literacy levels, as well as who may speak languages other than English. And so this tool has been introduced, but hasn't really been taken up more widely. And so we have a lot to learn about whether this could help improve some of the accuracy of screening, which some of our team's work identified that the MCHAT's not doing a great job, especially with children from minoritized groups. There's also a lot of work that's being done around patient navigation. So using health navigators, community health workers, promotoras, there's different terms for the same idea, but looking at whether we can better support some of those connections. So helping families on that roadmap of making connections between those different points. And this was a large study across multiple sites called Project Early, run by Emily Feinberg. And what they found is that families who received family navigation after screening positive for autism had a greater likelihood of reaching diagnostic ascertainment over the course of 1 year. And in particular, this effect was greater for Hispanic families. So I think that these family navigators seem to show particular utility, and this has been replicated in several studies across different conditions, helping families who speak languages likely other than English navigate this complex roadmap that I presented to you. And there's some ongoing work looking, that Project Early was really looking at connecting children from primary care to developmental behavioral pediatrics evaluations, but there's other work ongoing run by Jim Guevara here at CHOP that has been looking and found some impact of helping connect families, especially minoritized families, with early intervention services. So navigating the process of actually getting into Part C early intervention services. There's also a lot of work, because I think what we really recognize, I'm a developmental pediatrician, but one of only something like 700 or so across the entire country that are still practicing. And so we recognize that that is a tremendous bottleneck to diagnosis. And so there have been a lot of models to try to help support other community providers. So the Extension for Community Healthcare Outcomes Framework, or ECHO, has been used across a variety of conditions and specialties and geographic areas to allow for some virtual case-based learning, to allow for to help overcome some geographic barriers and increase access to some of that expertise and training where it otherwise would be absent. And so through here at CHOP, some of my colleagues have developed an ECHO autism model where it's a virtual learning network where providers, families, different individuals can come and actually speak with developmental behavioral pediatricians, neurologists, psychiatrists, and hear from them, present anonymized cases to get some information about how to help support. So ECHO is a promising model, again, to help just think about how can we increase some workforce capacity. And another element to that is that there have been a lot of models, including at CHOP, where they're working with training primary care providers to perform autism diagnosis and help advise about initial management, again, to overcome that bottleneck of subspecialty care. And so these pediatricians receive training, including the use of diagnostic tools to help diagnose individuals, and we're really targeting that toward individual children who have higher MCHAT scores, so indications potentially of more clear presentation. So we're not asking them to look at kids who have more subtle presentations, but where the diagnosis is less of a question, to help just expedite those children into getting interventions and services more quickly, rather than waiting for a diagnosis from a subspecialist. And I will say that there are some policy considerations for all of these things. We are lucky in Pennsylvania that state Medicaid, for example, will accept an autism diagnosis from a non-specialist with certain documentation, which is one of the components of this intervention that we're helping make sure that they're documenting appropriately with the right tools that will be accepted to allow the children to access autism-specific services. But I also know that there are states where that's not the case, and I'd be curious in Connecticut who's permitted to make an autism diagnosis and if that's an additional barrier. I also want to say that there are people who are working on AI and technology sorts of solutions to think about the diagnosis question in particular, or the screening question. I always add that there is a caveat to that. So especially if they're using older data where the predominance of autism diagnosis was taking place among white boys, as we talked about, the algorithm has the potential to produce biased results. So, we talk about like garbage data in, garbage data out. So we have to be really cautious when we're looking at tech solutions that we're not just perpetuating biases that existed in terms of the data that the algorithms are running. And then looking at this roadmap, I think there are ways to think about, can we also sort of meet families where they're at? Are there opportunities to really revise this roadmap? So thinking about things like, are there ways to meet families in the community to identify, to potentially screen them, or to have some of their concerns help expedite them into care. So I think in particular places like WIC offices where low-income mothers present and have a great relationship with some of the WIC providers because they're there frequently seeking nutritional support for their families, could be an opportunity. And Katie Zuckerman has done some work looking at screening in WIC offices. I think there's also a tremendous opportunity to really engage early child care providers. And one really stark example of this is I think that every child who gets expelled from an early child care or preschool setting should be seen for some sort of developmental assessment, because I will speak anecdotally, and I've been talking about how we can actually get data to support this, but so many of the children that I see who end up with an autism diagnosis have been expelled from preschool. And, I think about what that means in terms of, again, missed opportunities to help intervene, but just what does that mean for a child's and a family's functioning and a child's self-esteem, and how just truly traumatic that is. And so instead of just that being a traumatic experience, that should be an opportunity to really say, actually, this child probably really needs help if even early child care settings are not able to kind of support them in those locations. And then I want to be a little bit radical. I want to think about, like, can we actually bypass many of these steps that, I mentioned are really constrained by policy in a lot of situations where we are relying on a specific ICD code or, DSM criteria to make a diagnosis to help a child get services. But are there ways to do that and implement more behavioral supports that more universally, or to help think about, like, how can we just get children into support without having to go through all of the steps of that diagnostic process? I mean, part of this is, can we just define, what is an individual child's needs, and have that be irrespective of sort of a diagnostic category, and just help get them into services within schools? We can we think less about specific diagnosis as qualifying, and really think about just meeting the child's needs and doing more assessment sort of their developmental needs by domain. And I think people are starting to really think about this. I think schools are doing this more and more, but I think as a system, and thinking about also community-based interventions and autism-specific behavioral services and things like that, can we sort of bypass this from a policy level? So again, I'm going to kind of wrap up. I'm glad. I think I'm going to have about 10 minutes for questions, which will be great because I see a few things. I just see the chat highlighted. But really, this is a story about Ben and all of the children like Ben, where, our goals are, can we think about how do we decrease barriers to diagnosis and care? How can we increase support for primary care clinicians who are really on the front lines and, feeling really overwhelmed by meeting the needs, and knowing that there are bottlenecks at many of these steps across the roadmap that I presented. How do we really think about preventing some of these negative outcomes like school expulsion? And what does that mean? I mean, I sometimes use the term and think about, like, these kids, if they're not evaluated, diagnosed, and supported appropriately, are on this like preschool to prison pipeline. If we're really missing these opportunities to help them, where do they go from there? And what does that mean for, the child and the family? So I really think it's a social justice issue. And how do we just really think about improving access to services to help support developmental progress? I will say I continue to see my patient, Ben, and since diagnosis, his family is just so incredibly grateful that they can finally sort of understand what's been driving some of the challenges that they were seeing from very early on in his life. He has made tremendous progress. He's doing really well in school. He is a happy boy, and it's just been a delight to see how much it has meant to them that we've been able to sort of help identify some of his challenges and get him some of those supports. So I'm really looking for that more widely for so many of our patients and families. So, you know, I will continue to think about next steps and where do we go from here. And with that, I will take questions, I think with exactly 10 minutes to spare. So I hope I didn't talk too fast. I'm from right over the border in New York and speak very
You
quickly.
did a great job. Thank you.
Thank you.
Thanks so much, Kate. There are a couple of questions in the chat. Going back to the first one, they are wondering why age is still a factor in hindering diagnosis and treatment. Why is ASD still seen as a childhood condition, and adults who may never have the opportunity for diagnosis and treatment as a child but have symptoms are denied care?
It is not a childhood condition, and I am so glad you mentioned that. I mean, I'm a developmental pediatrician, so I see young children, and I think that, you know, we have a tremendous opportunity to intervene by diagnosing early and getting supports early on. But I also don't want people to think that if we don't diagnose early, that we can't help. We certainly know that's not the case, but you know, our mantra is still sort of the earlier the better to help provide some of those early supports. You know, there's some data on kind of neurodevelopmental windows and when interventions can potentially have the most impact, but that's not to say that even a late diagnosis is not tremendously important with respect to getting some supports, but also for self-identity, you know, a person's individual identity, for understanding some of their differences and understanding that there's a whole, you know, history and legacy to that that can be really empowering. So I hope that I'm just trying to read the question, make sure that I've answered it, but I don't think it's truly a childhood condition. But instead, another thing that we need to really do is help support primary care clinicians to, you know, really help think about supports that are needed sort of throughout the lifespan. So that is something I have been thinking a lot about. I will also mention I'm trying to undertake a project where we look at what sort of supports and services are needed within, you know, and I'm a pediatrician, so I think about the medical system in a large part, but especially if we're doing a lot more diagnosis in primary care settings, how do we empower primary care clinicians to really support individuals across the lifespan? So I think that's a really important point and question, so I appreciate that.
The writer of that question just had a follow-up that they have an
Sure.
adult. She's at the bottom. Yeah, an adult trying to find treatment who can't find someone who will diagnose him as an adult.
I mean, I don't see adults, so I struggle with this. I think we need to do a better job, especially recognizing that there are a lot of individuals who were missed as children, especially those with more subtle presentations who, you know, as the diagnostic criteria for autism has sort of expanded over time, that now would certainly, you know, meet criteria, but may not have come to identification early. So I don't know if anyone else has suggestions about sort of the local resources in Connecticut, but it is a tremendous challenge. Yeah, I know that there are a lot of adults who are struggling. In fact, I see a lot of kids where we make the diagnosis in the child, and through that process, the family's like, oh, that actually applies to me, because we know a lot of these things run in families, and there are a lot of characteristics and traits that run in families. So, you know, it depends. I also think what the individual is looking for. I've heard also there's a lot of like online tools and things that they're just looking to sort of understand their own needs and profiles better, but I can't vouch for any of those that exist.
So we have another question. Actually, we have two more. This one is a two-parter. Is there any data? How are the subtle presentations of autism being addressed as well? And the second part of that is especially in girls.
Yeah, I mean, we So I'm not sure at what time that, when in the presentation this question was sort of raised, if it was with respect to any specific piece. I think that where the presentation is more subtle is where I, as a specialist, can have a bigger role in helping to sort of have the time, the experience, the training to really sort of sort that out. And that's tremendously beneficial. I think part of the goal in allowing primary care clinicians to do more diagnosis when the presentation is not so subtle is to really think about, all right, how do we then use our workforce and the experience and expertise of the workforce in the most appropriate way? Like, do I need to spend 2 hours, or an hour and a half or whatever it might be with a family when their presentation is very evident within the first, a child's presentation is really evident within the first, 10 to 15 minutes. And would my time be better spent helping to work on, helping understand whether children with more subtle presentations meet criteria? I think that's definitely the case. I have, I know there's a lot of work also, and I have a whole cohort of young girls with more subtle presentations that, we can provide a lot of support to families just in helping to understand some of the challenges. I think some of these girls and kids with subtler presentations also really struggle because they often can mask, camouflage, their characteristics in certain settings like schools. And then they come home at the end of the day and they're absolutely exhausted from masking all day and from keeping it together and going along with the structured school setting. And so those are the kids where I think it's so important for families to really understand what's going on and why at the end of the day they're, having terrible meltdowns just because they are absolutely worn out from keeping it together all day. So I think, and I see that a lot with girls in particular, because they tend to have autism where they can sort of blend in a bit more and engage in social situations, even if it's not comfortable for them, and certainly can be exhausting. So yeah, and I think that's a big area where we're continuing to understand how to improve identification for sure.
We have one last question. Do you know of any studies for children with ASD with trauma?
Ooh, this is such a challenging, difficult question. I don't know if it's with respect to identification. There's some evidence of children who have been in really neglectful situations who present as if they have autism. Some of the most stark examples are kids coming from like the Romanian orphanages where a lot of them appeared to have autistic tendencies and interactions because they were in such neglectful situations. So there is some overlap of presentation with respect to autism and trauma. I know that, we still think about, are there trauma-informed sort of interventions? But I think that's an area that needs continuing information. I will say there have been some discussions recently. I'm part of the American Academy of Pediatrics Council on Immigrant Children. And actually, if anyone's looking for an area of study, there have been some just anecdotal comments recently about children who have been who are refugees and have been living in refugee situations where a lot of them are presenting with signs and symptoms of autism. So I think there's still a lot to learn about sort of the overlap of trauma experiences and where that may present as overlapping with autism.
Kate, we have some individuals wanting to know if they can get a copy of the slideshow.
Sure, I can send you, Eileen. I can make a PDF out of the slides I presented today and send that to you. I'd be happy to pass that on.
That's great. You sent me the deck, so I can just do the PDF.
I'll just say I have a bunch of hidden slides in there, so I would probably just want to take those out, which I can do.
Perfect. Thank you so much. And then
Sure.
Wendy, I'll send it directly to you, and I can post it on the webpage after we do post the video.
Thank you so much. This was a great talk.
Wonderful.
We
Thank
really
you so
appreciate
much.
you coming.
I appreciate the opportunity. And if you have any follow-up questions, you have my email and I'd be happy to chat.
Thank you. Bye-bye.
Take care, everyone.
Thanks so much.